And my logic with using my retina guys is I am going to send my patients to the retina folks when they're going to do something different than I am doing. And if they're just going to look at them and pat them on the back, the patient, I can pat them on the back just as easily here. And so I'm able to manage those patients and I'm keeping in my optometric practice longer than maybe I would have otherwise.
Hello and welcome to Crystal Podcast on iCode Media. Today I had a great conversation with my friend, Dr. Tom Nye. We talked about ERG in a practice. I'm going to name this episode Open the Box. And you can unpack why that's the case if you just listen to the conversations. As always, be sure to subscribe to the podcast, write a review, share it with your friends, and support those who support us.
The most common questions I get include, what ophthalmological codes or evaluation and management codes should I use? What ICD-10 codes do I need to bill with this CPT code? What CPT codes can be billed together and what can't? And my favorite, how do I manage a patient who has diabetes who comes in for a quote-unquote routine eye exam? These questions really highlight the confusion and uncertainty that serves as a daunting hurdle for providers, makes it more challenging for them to care for their patients and provide those patients with the best opportunity for a lifetime of ocular health and clear vision. That's why we built iCode Education for this specific purpose. Our mission is to provide optometrists with resources to help you understand disease states, revenue cycles, and billing and coding so that you can put that on autopilot and truly care for your patients. Check out iCodeEducation.com. That's EYECODE education.com. We've developed a premier billing and coding bundle that includes all of our billing and coding resources in one place. We also have a 10% discount code just for listeners of this podcast. Enter the coupon code EYECODEMEDIA22 at checkout. We'd love to work with you. Check out iCodeEducation.com. Unfortunately, dry eye and inflammation are part of everyday practice, and omega-3s are the foundation of helping patients with those two conditions that really play into one another. TG3 omegas are the formulation we use for our patients because it's a triglyceride-bound formulation, which means better absorption and fewer GI complaints. Patients who couldn't tolerate other omega-3s do great with TG3. For dry eye, MGD, and overall ocular surface support, it's our go-to. Check out TG3 omegas.
So, Tom, what I wanted to have you on today was to discuss sort of your process around the RETeval. You know, a lot of times doctors are kind of figuring out, like, am I going to use this? How am I going to use it? What types of patients am I going to use? So kind of take me back to that origin story for you related to the RETeval, and how did you come about deciding that it was something that you wanted to bring into your practice?
Well, first of all, I had been to a couple seminars about it. I had heard about it, talked to others, and I thought, this is something I want to get. And I actually pulled the trigger, got the unit, came in, and it literally sat in the box in my office for 6 months or maybe a year where nothing
No way.
happened. Kind of because we were swamped in the office. I thought my staff is going to kill me. It's going to be too much hassle. So it just sat there. And finally, my rep said, you're being a knucklehead for paying for something that's sitting there doing nothing. And I thought he was right. So anyway, I vowed I would start, and I was amazed how easy it was to implement. After sitting doing nothing for a year, we were up and running the same day or the next day once I opened up the box.
So actually your experience, Tom, is like a classic experience within optometry practices, not only based on our experience because usually people after the fact will come in and hire PPP and say, hey, I got this thing in the box and I want to use it and I'm paying for it, but it's just sitting there. So help me. As opposed to a lot of times what we would prefer to do is say, well, let's figure this out first before you spend the money. But that's the way that we work. And not only with that experience, but also we have the experience of survey data. So survey data tells us, I can't remember that I've used this, I've quoted this before, but basically survey data tells us like 71% of optometrists have a device that they purchased in the last year. We'll call it, you said sitting in a box, I'll say sitting in the corner, or sitting in a closet.
Mm-hmm.
And so what that tells me is like you had some, so I want to take a little bit of step back and say, well, you had some reason to say, this is going to be better for my patients. So you went to the seminars, what made you think it was going to be better for your patients?
Well, a couple things. First of all, we do treat a fair amount of glaucoma here. We do follow a lot of retina, a lot of macular degeneration, and diabetics also. But it was probably more the glaucoma and the macular degeneration that really drew me into it. And I thought, if I have an extra tool in my arsenal, I'm going to be able to treat my patients better.
Yeah. And so when you think about glaucoma, where do you find that it fits the best clinically?
We have done it on a pretty regular basis when we do our glaucoma workups, either every 6 months or every year. That's where we're plugging it in. And it's those patients that you're just not sure about. It just gives you one more data point. And there have been times where I thought, okay, this patient's doing okay. And then we do the RETeval and it comes back a little iffier than I realize. And then we might watch them a little tighter. On the flip of it, there are times where the RETeval comes back and surprisingly it's very good. It gives me a little more comfort level, or it gives the patient a little more comfort level to know that they're on track.
Yeah. And so, I mean, I think that's classic. I mean, one of the things that I talk about a lot is in a comprehensive optometry practice, we have time. Like, I know the way you practice. And so you've seen your patients for years and years. And so you don't have to usually make a decision right away. But what I'm hearing from you is that even though you might be able to kind of have time to make the call, it makes you more comfortable about making a call. Like, hey, I'm not going to put this patient on a medication that they otherwise don't need to be on, or have a procedure that they otherwise don't need to have, even though they got a messy field or some, maybe myopic stretch or something like that related to their suspicious looking nerves. But then on the other side of it, it's like, hey, if I don't have to I'm kind of uncertain. I don't want this patient who might be worried to go untreated if we're going to have progression. Well, then that can help me as well. So, I can see yeah, I can see absolutely how this fits into your practice. What about macular degeneration? You mentioned you manage a fair amount of AMD. How are you using it for those patients?
Well, and it's sort of the same thing. Sometimes people have just a few little drusen in the macula, but they're ready. They'll comes back and it's perfectly clean. Again, I'm not going to be sweating that patient quite as much as I would have otherwise. I might stretch out their next visit a little bit longer. Whereas, especially if I see progression, now we've had the unit for probably a year and a half, so I'm able to track it now, which is much better. The first time you do it, to me, it didn't make a lot of sense, but now that I can see the repeatability for the stable patients or the progression for the not so stable patients, that's really helpful there.
I did a talk about ERG not too long ago. I guess it was probably 2 or 3 weeks ago now. And one of the questions, and actually this seems to be a common question, more so if I were going to classify where I get the question, more so, I won't say where, but there are certain pockets of the country that seem to kind of, their mind goes to this place. And where it is, well, I don't see my retinal surgeons using this technology and the letters back to me. So why should I use it? Well, first, did you ever think about that? Do you have anybody that asked you that question, or did that thought go through your head? I've got some ideas about it, but did that ever go through your head?
Well,
like, why isn't the retinal surgeon, if this is such good technology, why isn't the retinal surgeon using it?
I don't want to pick on my retina friends, but oftentimes
you should. I'll pick on them.
Okay. Well, they're waiting till people are falling off the cliff. I don't want to wait till my patients are falling off the cliff and then we pick up the pieces later. I want to prevent them from staying away from the cliff.
Yeah, so my sense of, I think you're right. That's my approach. And you also would know my approach is that, like, we have to deal with the totality of the patient. When you're a retinal surgeon, as great as they are, you're a retina. you are a retina. And I know that they can say that they manage diabetes and all that kind of stuff. And they do, right? They manage the patient who has diabetes. I get all that. But like they're not, I mean, and they don't want to. They don't care about dry eye. They don't care about glaucoma. They don't care about like dry AMD. They don't want to see that. I mean, they care about it. That's not what I'm saying. You know what I'm talking about. But the point is that we've got to manage the totality of that patient for their entire lifetime. And we also, if there's nobody better, Kyle Clutie wrote a great Optometry Simplified article recently that talked about refraction and talked about the reason we are better, the reason we are different is because we understand both the refractive nature of the patient, and we also understand the ocular health aspect. And both of those things marry together. And when you think about things like, well, how long does it take to send a signal through the retina? And is that signal muted, right? Like that gets us insight into maybe this patient's overall visual function in a way that quite honestly, the retinal surgeon just might not care about. And so that's kind of my charitable answer. My non-charitable answer is to say, why the heck do we care? Why do I need a retinal surgeon to tell me that this test is valid or not valid? I don't need them to approve what I do. And so then that's where it gets to the certain pockets of the country where, I just do not like to abdicate my care, my authority to somebody else. And not just my authority, but my expertise and my value to my patients is beyond. The retinal surgeons we use are awesome, but they don't replace me. And so that's my rah optometry message.
Yeah. And my logic with using my retina guys is I am going to send my patients to the retina folks when they're going to do something different than I am doing. And if they're just going to look at them and pat them on the back, the patient, I can pat them on the back just as easily here. And so I'm able to manage those patients that I'm keeping in my optometric practice longer than maybe I would have otherwise.
Yeah. Amen. All right. So yeah, go ahead.
I was just going to say, and I won't probably mention other brand names. I don't know if we're supposed to or not, but at least around.
I don't mind if you do, but go ahead. You don't have to.
Well, at least around here, the Optomaps were poo-pooed away by the retina guys for.
Oh yeah, now they have them.
Yes, exactly. So optometry is ahead of the game, and good for us. And if they want to catch up later, they're welcome to. But to me, it's the same kind of logic there. Just because they're not using it doesn't mean that it's bad technology.
Yeah, agreed. Okay, that's one thing. Now I want to fast forward. So you were busy, you stuck it in the proverbial closet, and then your rep was the one that said, "Hey, Tom, you gotta dig that out of the closet, right? You've already spent the money." How did you decide to fit it into your paradigm, like into your practice flow? Like, we're like, okay, well, I'm going to look at my day and see which patients I think are going to benefit from the technology. Are you going to wait until you actually see the patient and then, hey, I want to do this other test? Like, how did you work in that? How did this work in your practice? Because what I find is that in my practice, it might work different than your practice, and your practice might look different than Ken Bull's practice, or Bob Lehman's practice, right? And so what was the process that you actually found it to be useful?
And that was one of my concerns is how am I going to fit it in? I thought it's going to completely disrupt the schedule. It really is not a disruptor at all. The procedure is very quick. But in answer to your question, most times we are doing it as part of a workup, whether a retina workup or a glaucoma workup. So it takes an extra 2 minutes in that procedure. When for glaucoma, we're doing visual fields and OCTs and things like that. That's usually how we're doing it. However, it's so slick that there'll be times where we have a new patient that something just seems weird, or I feel like, hey, this patient's not going to come back for the follow-up. I want to get this data point. And it's one test if we add on, my staff does not holler at me for adding on because it is so quick and so simple. And patients don't mind it either. It's simple for them too.
Yeah, I found the same thing. And what's interesting is, um, you know, like a field is gold standard, right? I'm not going to sacrifice a field for clinical situations. And I'm not going to exchange the field, but for whatever reason, and I think it's because patients don't really have to do a lot for this, right? They just have to sit there. Um, it's it doesn't seem as daunting. They don't mind it, and even though it gives me different information than a field gives me, um, I think that from a patient experience standpoint, they seem to get it more than a field. Like, what's interesting is, like, even though, like I said, field is gold standard, but you can tell a patient till you're blue in the face that the field is gold standard, and it's the thing that we use to make so many of our decisions. But when I say, when I equate an ERG to an EKG, they seem to just get it. It's like, oh yeah, that makes sense.
Hmm.
Um, yeah, so I think they seem to understand it pretty well,
Hmm.
without a lot of like detail.
Yeah, I would agree with that. And we've always prided ourselves in being on the cutting edge here. And it's part of that process too. They expect us to have the latest and greatest. And so they're very accepting of that kind of thing also.
For practices that want a clean, unified daily disposable system, the Clarity One Day family of lenses offers it. In my practice, it's been a strategic opportunity, not just another product, because one platform covers spherical, astigmatic, and presbyopic needs. That makes staff training easier, simplifies conversations, and provides a consistent patient experience. When a single lens family can do all of that, it becomes a natural part of our daily workflow. Check it out. If you're ready to stop feeling overwhelmed and start running a safer, more profitable practice, here's the next step. First, book a strategy call with us, Practice Performance Partners. We'll uncover the biggest risks and opportunities in your practice. Then, choose the package that fits your goals. From there, we'll get you launched with confidence, with clear systems, with expert support, and with peace of mind, knowing your practice is protected and set up to grow. Don't wait until something goes wrong. Book your strategy call with us, Practice Performance Partners, today.
So how do you practice by yourself? I can't remember. You have some associates too, don't you?
Right now, I am relatively by myself. I'm going to have a full-time associate joining me this fall. I've had a 1 day a week part-time associate for about a month now.
Okay. Walk through that process for me about how you're going to help them understand the value of it. I'll take a step back and say, so I've got two associates. We all practice slightly differently, and part of that's because we have different patient populations. I'm the oldest of the three of us. I've acquired most of my dad's patients along with my 18 years of practice. They've got some of my dad's patients, but by and large, my patient population is an older population than theirs. And so we're going to have variances. What's your plan to help them understand not just this tool, not just an ERG, but also all the other tools that you have in your practice so that they can hit the ground running and kind of implement sort of a process that doesn't feel disjointed from what your process is currently? So that when a patient is like, well, Dr. Naya did it this way, why are you doing it that way? What are your thoughts about that?
Well, we have protocols kind of spelled out, and for the glaucoma workups or for the retina workups, it's just in that protocol spelled out. So if they follow the protocols, it'll just be part of the game. The one thing that we haven't touched on too much is diabetics. We actually, in our office, aren't using it for diabetics as much as I thought, and I was thinking about it preparing for this. I'm not quite sure why that is, but that is definitely an area where I'll kind of throw it in at the last minute to my staff. And again, they don't seem to mind. So that's something that we don't quite have a protocol for. But if that patient's coming back every 6 months for a diabetic follow-up, it's definitely part of that protocol too.
Yeah. Well, I think what's important is I think you're right. Like, what I find, you've heard me talk about this before, is it's that if you have good protocols set aside and you have good reasoning behind those protocols, whether they're based on clinical practice guidelines, large studies or large, consensus documents like DUs 1, 2, and 3, preferred practice patterns that can become the standard, then you sit down and you say, well, here's our standard. Of course, every patient is unique. Every patient is different. You don't have to make every patient go through a protocol. And really, you probably shouldn't. But what you should ask yourself is, if I'm deviating from that protocol, why? Is there a good reason? And what you'll find largely is, like, there are good reasons, but most of the time you don't have a good reason other than like maybe laziness or, and I'll say that to me myself. It's like, well, I got too busy today. I couldn't do that. So I think the key is establishing good protocols for your practice, having good, clear communication with your associate doctors about what do they believe is important within their clinical practice and within the management of this patient. And so that they can take ownership too, because they got to make those clinical decisions. And then they have to decide, yes, I'm going to follow this protocol 95% of the time or 90% of the time. And the exception doesn't become the rule, as opposed to like, okay, well, this is a one-off case. As far as diabetes go, I'll tell you that I think a lot of times people, my patients who have diabetes in my population are relatively well cared for. And I think I've said this before, maybe on the podcast, maybe not, but they're relatively well cared for. My practice is in a relatively affluent area in Omaha. It's not where I was trained. Where I was trained, I don't think I ever saw a patient who had diabetes that didn't have at least moderate retinopathy. I mean, I'm not even being bombastic. Like, that's where I was trained. And so I think the reason that I'm seeing what you're seeing as far as diabetes goes is because I largely don't have retinopathy in a large percentage of my patients. So I might have 25% of my patients who have diabetes have some form of retinopathy. Now, that's not to say that those patients it wouldn't be valuable for. That piece of information is probably valuable in certain patients without retinopathy. And in those patients, it might be that they've got a really high A1C recently, or they've been really out of control, but it's not been long enough yet for retinopathy to develop. And so we might want to say, listen, you're kind of out of control. Let's see how your retina is functioning. Do we need to see you back sooner, or your retina is functioning fine as long as you get your A1C under control? We can see you in a year. You know what I mean?
Yep.
So I think that's probably why I'm seeing the same thing you're seeing, was where I thought, oh, diabetes. I'm going to see a lot of my patients who have diabetes, but I think mostly it's because I'm waiting for retinopathy. Now, I think Bradley Grant would probably make the case, and not wrong. I mean, he could make the case and argue to me all day long that, hey, I'm giving better care. That's fine. I think that's really fine. And I think as long as you have mechanisms in place to say, hey, Mrs. Smith, I'm not seeing any retinal changes. I have this test. It's likely not going to be covered by your insurance. You can pay out of pocket for it if you like it, and that will tell us. It'll give us another indicator about how your retina is functioning. And we know that patients who have diabetes, their retina might function worse, maybe I would say sick, but worse than I otherwise might see it this way. So I can see that. You could totally make the case for that. But I don't know. What do you think? Do you think that's why you're not using it as much for patients with diabetes?
I think that is probably correct. We have pretty good diabetic patients. We see a lot of diabetics, but once I started drilling down, I realized that most of them are pretty well controlled.
Yeah. Yeah. And I would say my experience has been, because of that, when I do have patients who have retinopathy, there are times, I mean, so I'll take a step back and say, all right, well, I'll play devil's advocate, right? I'll be the person from that zone of the country that says, why is my retinal surgeon not using this, right? And I'll play devil's advocate and say, well, does it always change my clinical recommendations or my discussion with the patient? No, it doesn't. But it does have the potential to. So when I order it, in many cases, like, again, I'm telling you, my patient population is relatively affluent. They're relatively well managed. But if I see mild retinopathy, I have no problems ordering the test, because I know that if I get a DR score that's low, I'm likely going to say, Mrs. Smith, great news. We can continue to monitor you on an annual basis. You've got mild retinopathy, no DME. So we're going to monitor you on an annual basis. And this score also helps us reinforce that your retina is functioning well. On the other hand, it also has the potential for Mrs. Smith, who I'm thinking, well, you got mild retinopathy and your A1C is low. Do I see you back next year? Oh no, your DR score is really high. No, I'm going to see you in 6 months. And Mrs. Smith is like, done. Like, I'm happy to do that. Right. She likes that extra level of care because it matters to her.
Yep, I would agree. And we're circling back to the associate doctor thing. The reports are so easy. They make it very simple to use, RETeval. You look at the reports, you get that DR score, and even for the first-time user, it's pretty simple to interpret. And I've already set up my associates with the, blanking a little bit, the RETeval.
Oh, yeah. Yeah.
That's really helpful also. So, little plug for RETeval. They give you the tools to be successful almost immediately.
Well, I'll tell you, actually, I'll give another plug. It is a course on iCode, but if you want to become a wonk, or you want to listen to a wonk on ERGs, Nate Lighthizer, I think, has a 3-hour course just on ERGs and VEPs, and this was even before RETeval was available broadly. And it's just complete CE. All it is CE. But in addition to that, yeah, I mean, if you want to open a can of worms and go down a whole bunch of rabbit holes about what ERGs are going to look like in different disease states, it's all there for you. So what I like to do is, when I think about where I'm going to use it, I try to get myself because again, I would say I am an adequate ERG reader for the horses that I see. But the zebras, I got to go and brush up. And that's where I find that the RETeval the RETeval Academy is very helpful, is that it's like, so first, before I order the test, I'm thinking, well, here's my differential. What are the differentials I'm thinking about? What type of ERG might I want to have? And then I'll order that ERG that helps guide me. And then I can start to say, okay, well, this is what I expect to see in that based on those differentials. So that's how I find, and that's how I'm using it, as opposed to like this massive dump. It's like, to your point, I get really comfortable with it, like the common stuff I see. And then when I have it in those unusual places, I try to plan for where I think it's going to be useful, what I'm going to see. So I'm not just ordering it and being like, I don't know what to do with this, Tom.
Yeah.
That's how I've used it.
Yep. And again, now that we're getting repeat patients, that's even more impactful, because I can see, again, is there progression? Is it staying the same? So, I've been happy.
Yeah. So, okay. Well, then, kind of your sort of bottom line, when you think about, how do you apply your experience with your ERG to maybe new technology? So what would you do differently? So this is kind of more broad, but like the exchange is coming up.
Mm-hmm.
And let's say, well, first question I want to know is, if you would do it again, if you were going to purchase this again, what would you do between now and a date of delivery? Let's say you're like, I'm gonna get an ERG,
Mm-hmm.
and I'm gonna get it at the exchange because I'm gonna save some money. And then, like, what would you do from now till when that was delivered, so that you can hit the ground running and this thing doesn't just sit in the closet for a year?
Well, I guess if you're really proactive, jump into that RETeval Academy, or do things like that. Study up on it. But even if you don't do any of that, just open the box when you get it, because it's very simple. Training for staff is also included on the RETeval Academy also, and the staff picked up on it very quickly. Usually when I bring new technology in, I get the groans and the mumbles from the staff. But this was one of the simpler ones to do for them.
Yeah, I think that's a good point. And I also think that, I will make the case, sometimes people will grumble about disposables. But, one of the nice parts about having a company, and I'll tell you that the differential between, so I'll just make the comment that the differential between the Medicare national average and the cost of the disposable is enough that it's the disposable doesn't make you feel like, oh man, I'm spending so much money to get this information, right? But what I do like about that is that you if you are a user, you're going to get support ongoing, right? Because you both have skin in the game. And that's why you see things like RETeval Academy. You see things like your reps are there to support you. If you're a user, right? I don't know, my machine has not gone down, but knock on wood. But my assumption is if my machine goes down and I'm a good user, right? Meaning a good user in the sense that I'm finding patients that benefit from the technology. And there's almost like a little bit of a partnership. So I don't know. I think there's something to that. Optos is similar, right? Like, especially if you lease the equipment, right? They don't make money if it's down, right? Your lease says that if you're leasing from them and that equipment's down, they want it back up fast because they're losing money. And so I don't know. Those are kinds of things are like, I don't know. They're just things to think about.
Yeah. And I think along that line, sometimes doctors ask me, well, how much will I use it? Things like that. I would think in a typical optometry practice, and you know numbers better than me, I think without breaking a sweat, the typical practice, 2, 3, 4, 5 times a day, you're going to use this.
I think you're right. I think if you're managing chronic ocular diseases and you're thinking about, again, the holistic patient in front of you, thinking, I wonder if they have visual dysfunction beyond 20/20, beyond what I can measure on a Snellen chart, and you're just curious about that, and you think, again, this is not me trying to convince you, but if you believe that that piece of technology can give you more information, in which case you can either make more accurate clinical decisions, or you can help counsel the patient better based on their disease state, then if you believe that, then this is one way that you can you will use that technology a lot. And I'll say that the more that you use it, the more you find like, oh, I didn't think I would use it for this.
Mm-hmm.
Okay, it's helpful. I didn't realize how helpful it would be. I didn't realize how much a patient would appreciate the conversation just in understanding that their retina is not functioning as well as they may have, and that can explain why they might have the sense that they're not seeing as well as they otherwise ought to be. But I wouldn't be able to explain that because of their Snellen acuity.
Right.
Yeah. Yeah. Well, Tom, I want to be respectful of your time. Tom, any other parting thoughts? Any way that people can reach out to you if they've got questions for you?
Well, certainly, they can email me, go to our website, things like that. If they don't have my contact information, if they have my contact information, they're welcome to call me on my cell or something like that. But for me, this is one of those no-brainers. Reimbursement is good. If people are always concerned about return on investment, to me, it's a non-issue if you open up the box.
I just want to call this episode "Open Up the Box" with Dr. Tom Nye.
Yeah.
Tom Nye, thanks so much for coming on. I can't wait to see you in Nashville.
Okay.
If there's anything you need, please feel free to reach out.
All right. I appreciate it. Thank you, sir.